So I'm Edwin Jones. I am a service development consultant in South Wales, work for Abertawe, Morgannwg University Health Board, very catchy title. And basically what I do is I do some work around developing training programs in positive behavioural support. I do some research and I do some service development. So I work with social care partners, developing mainly supported living, small, ordinary, community-based housing for people who are labelled as having severe challenging behaviour. And we try and do lots of work with the provider organisations to skill up staff in PBS, and we've had some really nice, good successes there. So people who previously have been in very restrictive environments moving to have ordinary lives, being part of the community, and a particular interest of mine is in active support, which I've been talking about in the conference, and how really staff can really help people to have a much better quality of life. I've been talking about how active support is best seen as the foundation for primary prevention within PBS. So really, primary prevention is about the most important thing in PBS, which is about organising the environment to try and ensure that people don't need to use challenging behaviour to meet their needs. So you try to just make sure that people have a good quality of life, and by doing that, a side effect really is that we see reductions in challenging behaviour. And of course I think that's the best way to reduce restrictive practice, because if people don't have challenging behaviour, then there's much less rationale for any restrictive practice. So kind of quite briefly really, active support has been around for around 30 years, and really the revolution happened in the sort of early 80s, where people started to develop the first early model projects. And at that time it's quite difficult for us to think like this now, but people really didn't believe that it was possible for people with learning disabilities to live in the community. Most people were living with their families, but the people who weren't were in large institutions. So some very good people started thinking that perhaps if people lived in more typical ordinary settings, like most of us do, then that would be the best way really for them to have a good quality of life, and also to be able to develop skills, competence, friends, relationships, all the important things. And those were very successful, showed really good outcomes. And then what happened really was people got the message about small, ordinary lives, small, ordinary, typical houses. But unfortunately, the message about active support, really, about what staff do, how staff support people, how staff interact with people, was lost in a lot of places, not all places, but generally was lost. So what we saw was people living in better physical conditions, but actually having a very similar life to what they had in the institution, which was mainly, unfortunately, particularly for people with more severe disabilities, having their lives wasted. So because staff didn't have the skills or didn't have good practice leadership, basically what tended to happen is the staff role became one of doing things for people, rather than helping people to do things. And in the early days, the whole idea was that the staff role was to help the person to engage in a whole range of activities, help the person to be part of the community. But unfortunately, without that focus on active support, we saw people who just did very little spent most of their time disengaged. And we know that's, pardon me, we can edit that bit out. We know that's a real risk factor for challenging behaviour, because people use challenging behaviour to get away from things they didn't like, to get things that they did like, just to have more social attention, or to just change their levels of stimulation. So in the conference, I presented some data really that shows that when we see staff helping people to engage in activities, we see a reduction in challenging behaviour. So there's a correlation between those two things. As participation increases, challenging behaviour decreases. And that's a very important finding. It goes back to the original theory behind positive behavioural support and active support, and that's the same set of theories really coming from applied behaviour analysis. And we talked about that a lot, and I was saying that what it shows is there's a relationship. The data, we can't say scientifically that it caused that. In one or two cases, we have scientific data that can say, yes, the increase in participation looks like it caused a decrease in challenging behaviour. But really, we need a lot more research around that. And I know there's lots of good work happening amongst BILD members out in the field, and a lot of people are doing active support. So I was just hoping that we could do some more work together around that, and that we'd need, from those organisations doing that work, if we could work together and just develop the evidence base a bit more and test out some of those theories. I think we've learned a lot. Some of the key messages really are changing the setting is important. So we need to help people to live in ordinary, typical environments, because those environments are very rich. It's if we have people living in community settings, living in their own homes, then that's really good, but that's not enough. What we also have to do is make sure that staff have a technology of how to help people to engage in activities, to do things that they find rewarding and enjoyable, and to develop social skills, social relationships, and be really not just present in their community, but be part of that community. Those things aren't necessarily easy, but it is possible. So what we need to do is support staff by giving them, by training them, so that they understand more, they understand how to do that. So we need to train them mainly in what I would call positive interaction, so that they give different levels of help according to the person's needs. So when somebody can't do something, rather than do something for them, they give them a high level of more help to do something. And also just that a good approach is to break an activity down into steps, do things one step at a time, and you vary the level of help according to how difficult the person finds a particular step. And to use things like, for some people, for some activities, backward chaining might be a good idea. So rather than start at the first step of an activity, you might start at the last but one step before they get a reward. So for instance, making a piece of toast. Rather than start by helping the person to get bread out of the bread bin, if they've never done that before, it's very difficult for them to realise that by doing that, they'll end up having a piece of toast. We know it's often good practice to actually start by helping them to cut the piece of toast in half after the toast has already been made. Butter's been spread in it, jam's been spread in it. We simply have the person to cut it in half and then eat it. And when they're used to that, if somebody's never ever done that before, that's a good place to start. And then gradually we work backwards by, after they're okay with that, we help them to spread the jam on it, cut it in half and eat it. And then once they're okay with that, we've done that quite a few times with them and they're quite used to doing that, then we help them to put the butter, then the jam, then cut it in half. And these things we know these things work. There's a lot of evidence about this being a very effective practice. But some of those ideas were lost, really. We didn't train staff around that. So some staff perhaps thought about that and did it themselves, but really we want to ensure that all staff do that. And the other part of that model of positive interaction is that we reinforce the behaviours we want to increase. So we give people praise and attention when they're engaged in activity, and we ensure that they get the reward, like eating a piece of toast quickly, and so it's an enjoyable thing for people. And there's other parts, again, that are important to that model, things like effective planning. So planning on a daily basis, what activities the person's going to do, having a mixture of things, having time to have a rest as well, and which staff are going to support them. And if we're working in settings where 2, 3, 4 people live together, and you've perhaps got 1 or 2 members of staff supporting them, it is quite a technique, really, that you have to staff have to think on their feet and do that. And it's just a way of helping them to do that. We'd also have things that we called activity scripts. So some people think routines are bad. And I think, well, and not only me, quite a lot of people think that routines can actually be very helpful. We all have our own personal routines. If we think about what we do when we get up in the morning, most mornings we do our personal care in pretty much a similar way, really. And if you think about it, if you suddenly get interrupted, if an unexpected thing happens during that time when you're perhaps getting ready for work in the morning, that can throw you a bit. So that tells us that these routines are helpful. And as long as the routine is person-centred, it's a routine for a person. A good way of helping the person is to ensure that all the staff supporting them know the person's routine and helps the person to follow that routine, because that helps the person to be very independent. They know what's going to come next, so they don't really need a prompt for it. They can just carry on and do it. The problem is inconsistency amongst a staff team, and there might be very good reasons for that if we have relief staff working or things or staff that don't know the person very well. So a very simple idea is to write that out. So that's what we mean with sort of an activity script like that, so all staff can follow it. And then that helps us to think, where do we need to give more help? Where do we need to fade the help so the person can become more independent? And then there's other elements which develop that further into a more structured skill teaching approach. And so I think what we've learnt is we need to help staff by giving them that technology so they can do more of that. If we don't, most of the staff are very good people, very nice people who come into the work to really make a difference in people's lives. But unless we give them that technology, it's very difficult for them to do that. So I don't think it's staff's fault. It's the fault of more senior people, perhaps like myself, who don't work with staff, train them and support them in that way. And we also know increasingly how important practice leadership is. So we need somebody who can do that on a regular daily basis with staff. And the same approach that we use with working with people with learning disabilities is the same approach we should use with everybody. So we want to let people know when they're doing the right thing. We need to be much more, less telling off of staff, less punishment of staff, more saying, yeah, you've done the right thing there, that was really good. So we reinforce the behaviours that we want staff to do more of. So a practice leader is really somebody who understands that technology very well, who's done it themselves, and who can then coach the staff around doing that, and let the staff know when they're doing the right thing, and perhaps when they're not doing the right thing, rather than lecture them and tell them off, is simply show them the right way, role model what the right way of working is, and when we have that going, then we see great benefit for the people who we're supporting, really. And what's really good is certainly in my area in South Wales, now we have some excellent practice leaders, and they've really developed the practice so they can come back and suggest different ways, innovative ways of doing things. And you get this really positive, virtuous circle going where good service quality improves, we see really good outcomes for the people being served. So the 5 service accomplishments really being achieved, around competence, around people being treated with respect and dignity, around participation in activity, and you know it's much more satisfying for staff to work in that way, because that's why they came into the work in the first place, most of them, and they have a better, more job satisfaction, and they see the people they're working with having a much better quality of life. And I think that's what we need to learn from our past, perhaps, mistakes, really, is that we need to change settings so people have their own homes, live in the community, but really have skilled staff to support them. And if we think then about people with challenging behaviour, if we don't have that, we see high incidence of challenging behaviour and often high use of restrictive practices. So really, what I was talking about in the conference particularly is how active support can be used as a way of improving quality of life and reducing restrictive practice. Okay, a good PBS plan really should be understandable. And I know that sounds obvious, but I read a lot of them that I quite struggle to understand the language. So we need to think about who's the audience for the PBS plan. So it can be, the person themselves, but usually it's the people who support the person, because they are the people who implement the plan. So the first thing is the language too complicated? Do they understand it? Are we using too many words? And it can be quite a skill to say things succinctly and say the key things and express those very well. So we need to think about just the language that we use in a PBS plan. It should be straightforward, it should be understandable, and we can check that out by asking staff, do they understand it, and looking at what they do and working out, do they understand the plan. And what we should do is adjust the language we use in the plan. The way we write PBS plans now locally is in the first person, so it's in the voice of the person whose plan it is talking, and we find that is a very good technique because it helps us to be conscious about how we're presenting information about the person, really, that we're being respectful, that we're covering the key things that are important to the person. The PBS plan should be a mixture of things this comes from person-centred planning, things that are important to the person themselves, and things that other people may think are important for the person. It shouldn't, a bad PBS plan is everything that the professionals think is important for them. We have to make sure that we include things that are important to the person. So it could be, really very good preferred activities. Little things, there's an issue about whether people smoke or not. But if somebody does smoke, okay, we should help them perhaps to reduce smoking, to cease smoking. But until we've helped them to do that, it's quite important for them to have a cigarette. Probably not a good example, but a good way of getting the point across. The other thing about a good PBS plan is that it should be mostly about primary prevention. It should be mostly about how do we help the person to do the things that mean that they have a good quality of life. That should be the biggest section. I see things that are called PBS plans, which I would actually describe as behavioural management plans. So they're all about what happens after the person has challenging behaviour. Primary prevention are the things that we do before the person has challenging behaviour to try and stop challenging behaviour happening in the first place. So a good test for me always is to look through the plan. Is it mostly about reactive strategies? Is it mostly about secondary prevention? And is there, how much is there about primary prevention? Good PBS plan, most about primary prevention, because then you don't need a lot about secondary prevention and you don't need a lot about reactive strategies. In our PBS plans, we do have secondary prevention things. So that's when the person's becoming agitated, when it's more likely that they're going to have challenging behaviour. How do we get in quickly then to change those triggers, to remove those triggers? So we help the person to de-escalate, to calm down, and so we don't see challenging behaviour. We have a section on reactive strategies, but we're trying to reduce the use of restrictive interventions and reactive strategies all the time. An important part of a PBS plan should be thinking about how that can be reduced. It's important just to write the specific reactive strategies that that person requires. Nothing, no general stuff, just exactly what. And very often, if we understand the person well, then we don't use hands-on physical intervention. We are concerned about how close people are to the person, so they maintain a safe distance. So if they do get the person sort of is physically aggressive towards them, so they can break away quickly. What I should have said perhaps earlier is a good PBS plan has to be based on a functional assessment of why the person has challenging behaviour in the first place. So before the PBS plan, really there has to be a functional assessment, and our PBS plan is based on what we understand about the reasons why the person has challenging behaviour. So the primary prevention stuff would be understanding the triggers for challenging behaviour and trying to remove or modify those triggers in the first place. So that's kind of how it works. I think we're getting better at developing PBS plans, and I think we have some examples that we could show, because I always think it's much better to show somebody an example of what's good, and then they're going to understand that a lot better. I also have seen some very nice innovative work where, rather than trying, well, we write down how we should interact with a person, but a few video clips can tell 1,000 words, really. So, what tone of voice should I use? What should my body language be? How much verbal assistance or how much non-verbal assistance should I give? Or how, what works with a person, really, in terms of the way I talk, the way I act with them. And some lovely work done by staff teams themselves about videoing that. And then when you're training new members of staff to get to know the person, you show a few clips. And it's very early days, and it hasn't been formally evaluated. But to me, it just seems eminently sensible.